Okay, so thanks again. What we want to go over today is just briefly kind of the why of data collection and folks with behavioral health needs in particular, although we'll also talk about people with other sorts of complex needs, developmental disabilities, intellectual disabilities, brain injury, trauma, those sorts of other layers to this population. But laying a little bit of the level setting at the start. And then we'll also give you a couple points from the community self-assessment that I know many of you filled out. That was the survey that we used early on when we started the Impact Network back in 2021, and then again, very recently with all of our sites. And we had some specific questions in there around the data piece. So we'll give you some high-level results from that. And then I'll turn it over to my colleague, Reggie Herder, and she will talk about some specific, really concrete level questions around data and this population, again, at the jail stage at intercepts 2 and 3 for sites to consider. We'll also talk about a resource we have upcoming around that content. And then we'll turn it over to 2 of our sites today. We're going to have a spotlight on Douglas and Sarpy County, Nebraska, both Impact Network sites, and we'll hear a joint presentation about the data focused work that they've been doing through the Stepping Up initiative and otherwise. And then finally, we will turn it over to our research area, Sam Zatola, and she will talk a little bit about the population of folks with frequent jail contact or familiar faces, maybe another term in particular. And for those of you who are in St. Louis, you heard some related conversation around that population. And this time we're going to focus specifically on that definition piece. So defining who that population is as kind of where to start. We also have some resources around that topic. So we'll get into all that and have time for questions. Feel free to put questions in the chat throughout the call, and we'll have opportunities to unmute and ask them as well. So just, again, high level, if we're not bought in already, why do we need to know or have a really good picture of who is in our jails? And I think we probably could all speak to this, regardless of the intercept in which we work. But number one, obviously is, or I don't know if we would rank these, but all of pretty high importance. We know that the SJC sites have focused on jail reduction and population reduction for, in some cases, several years. That overall jail populations have been reduced in many sites. However, we also know that in many cases, there are racially disparate populations as far as those reductions. So we know that a lot of the strategies throughout the SJC that sites have been using have reduced the white population of folks in the jail, but not necessarily addressed racial disparities or allowed the same reduction in folks of color who are in local jails. We also know that relatedly, people remaining in jail are more likely to be folks of color versus people who are white, and they're also more likely to have mental health and other complex needs. So we know in our work with sites providing behavioral health focused technical assistance, we've had that conversation with several sites around overall jail population reductions, but that percentage of people with behavioral health needs is rising. And for reasons that probably we can all provide, but another big area of focus here. We also know, as we mentioned already, that people in jail and prison, really throughout the criminal justice system, have disparate rates of acquired brain injury and intellectual developmental disabilities. We talked about this in St. Louis as well. So another focus population here. And then just generally, really across all of these folks of color, these other sorts of co-occurring needs, we know that those people are often staying in jail longer, that they have longer lengths of stay. So another reason to really try and get a good idea of who is entering the jail, how long they're staying, what's happening at that intercept, and then reentry on the other end. And as I said, I just want to give a couple of high-level pieces of information from the community self-assessment survey that we sent out. As of today, we have 58 responses across both cohorts 1 and 2. As I said, we had a few questions specific to the data piece. So one of them is we asked if your jurisdictions, criminal justice and behavioral health agencies share data. And 69% of respondents said either yes or yes with limitation or maybe not yes, but they are planned or underway currently. So there is data sharing in the majority of the respondent sites across the impact network. We also asked that same question between criminal justice and disability services instead of behavioral health. And you can see that that number went way down. So only 27% of sites answered in those groups, yes, yes with limitations, or planned or underway. So again, kind of emphasizing that this is often a population of folks with other disability and complex needs that potentially gets overlooked at the point of the JIL. We also asked about just collecting data around racial disparities across the criminal justice system. And I know that that could be pretty broad, but 34% of respondents said yes or yes with limitations. So about a third of folks. We asked finally about this idea of universal validated jail screening. And we asked that question from a couple of different angles. One was specific to mental health, validated screening for mental health. And 68% of respondents said yes or yes with limitations. So the majority of jails in particular, but again, this language is a little bit broad, are screening for mental health needs. And we recognize that those terms universal and validated may have eliminated some of the yes responses, but we really wanted to get a look at sites that are well, essentially using validated universal screens. So we know that validation is important, as all of you know, so that we're screening for what we think we're screening for. So again, 68% of folks. We also asked that question around screening for substance use disorder. So a little bit lower, 51% of respondents said yes or yes with limitations. And then finally, screening for other disabilities. And again, you can see that number drop quite a bit from mental health and substance use disorder. So only 27% of respondents said yes or yes with limitations. So just kind of a high level across impact network sites. And obviously we have more work to do. So that's part of why we're here. So now I am going to turn the next several slides over to Steve Herder and talk a little bit about even a more detailed level of these questions.
Hey everybody, great to see you again. And yeah, I'm just going to go through 4 slides. They're fairly dense, but wanting you to think about, do you know if you guys are collecting any of this kind of information? And then also, are you analyzing it? A lot of times we're very data rich, but very analysis poor. So are we analyzing the data? And then are we using the data to help drive or guide our policies and our different kinds of strategies? So I'm just going to hit some of these, and we're just kind of thinking, as I go through them, are you collecting these? And do you know if you're collecting these? So this first set is really more specific to mental health. And you're going to see times when I'm talking about mental health specific, and other times when we're talking about broader category of behavioral health, which for me would be including, or us, who would be including mental health and substance use. And then of course, other kinds of disabilities, but more in particular, the mental health and substance use populations. And so part of that in mental health is looking at, are there different categories inside the facility? Depending on the size of facility that you might have, this could really vary. But are we collecting just kind of general mental health, or identifying general mental health, or are we really looking at the different kinds of levels of the mental health population, from those who are less acute to high acuity? And are we able then to really understand the delivery of services that are going on for those different levels? And then what is the population that's in your isolation or segregation cells by race, ethnicity, and level of mental illness? You can imagine that there's oftentimes when persons, especially persons that may not be on medications while they're in the facility, but otherwise could be more stable if they were on medications, may actually end up in segregation or isolation cells, either for their protection or because of other behaviors that are taking place. And so we want to be able to pay attention to that, and then what kinds of services are taking place for them while they're there, what kind of care is taking place. And then also by race and ethnicity, because we often see an overrepresentation along that line. So who's receiving crisis stabilization in those different kinds of categories? And then what are you doing to document disciplinary reports? And are we really looking at, and then again, and analyzing race and ethnicity by those different kinds of disciplinary reports that may be taking place? If you go to the next slide, Ashley. So now being a little bit broader in the scope and looking at what we're tracking around the number and prevalence of individuals with behavioral health needs in the jail. I recognize that a lot of this data, if you are working on the custody side, you may not know because it might all be being tracked by your jail medical persons. And it might be in an electronic health record that you may not actually have access to. But hopefully what you are doing is being able to work with them to extract this information so that you understand it. And also, how is your jail medical and your classifications and your housing all working together to be able to support people to help keep them in the safest place possible, and also the delivery of services. So one of the big areas, of course, to start with is always going to be around screening and assessment. And so is there actually a standardized, validated tool that's being used at the initial screening? And so right when they're coming in, so that might be in that kind of first hours of arrival. And then we might think about a further assessment that's taking place later on. And there's another question in here that we'll ask about, when is that second greater assessment taking place? So in that initial kind of screening, are we again asking about mental health and substance use disorders, but also our intellectual developmental disability, the acquired brain injury, again, you've heard that language before, hearing, other kinds of disabilities being identified. As a jail provider, correctional provider, do you even know what kind of questions are being asked? Would be one of the probably great places to actually start, being able to really look at that particular tool. Is there also a way that you're identifying those persons, and this is something Sam will be talking about later on, that have frequent contact with the jail? So we being able to kind of tease out, extract out easily the data to start analyzing those, who's coming in frequently, what they're coming in on, how long they're staying with you. All that becomes really important, and what kind of housing are they getting, and what kind of services are they getting. That time between that, again, that initial screening and the full assessment, a lot of times what we'll hear is that the initial screening is within 24 hours of people coming in. Sometimes it's 48 hours. But the full assessment may not be for 2 weeks later. Sometimes medication gets caught up in all of that, that we may not have persons actually receiving the medications they need to have until that full assessment's being done. So something to consider, that that's probably not fast enough to help people stay consistent on their medications. When they're being kind of screened in for services, is there any kind of specific kind of caseload that lends to? So persons, especially that are higher levels of acuity, serious mental illness, serious persistent mental health, are they actually getting a higher kind of level of maybe a caseload that somebody's checking in with them on a regular basis, in addition to certain kinds of housing? And when is that taking place? And then thinking about the withdrawal needs. So we all know we're living in an age where there's very, very high substance use disorders, in particular substance use disorders and managing withdrawal, whether that's alcohol. We often don't really kind of pay enough attention to alcohol withdrawal, but also opioid and other kinds of withdrawal. And are there very specific kinds of things about how that's documented? Are you using the wows or the cows, for example, for opioid use disorder? And then we also tracking kind of related issues. So sometimes persons really need to have water with electrolytes. Are there certain kinds of food and kind of weight management, because people can rapidly lose weight, especially with opioid withdrawals. And then medication. So our medication assisted treatment that's taking place, or medication opioid for opioid use disorder. And then outside of the kind of initial screening that might be taking place, is there a referral to specialists? So if your jail is not equipped to manage specific kinds of services, are there direct referrals that are being made, and who are those referrals being made to? And how is that being tracked? And what is the outcome of that? And what's the kind of care management that might be taking place once they've been referred out? The other part, and the last part of this particular slide, is those mental health services and versus substance use services. So what's the total number of folks who are on psychotropic medications, the total number of folks that are on mental health services substance use services co-occurring. So are you able to really kind of understand and dissect all that information and being able to track that? And then what kinds of treatment services they are receiving? Are there any individualized treatment plans, for example? And are there any kind of non-pharmacological types of services that are taking place? Like EMDR is a great one for trauma. So if you know somebody that is in your facility, are they receiving that? Any kind of group treatment? Do you have specific kinds of pods or units within your facility where folks can be, but it might be more of a mental health pod or a substance use kind of treatment pod? Go to the next slide. Just a couple other slides here. One of them, in actually continuing, is again that psychotropic medications. You've heard us say before that most of the time medical kinds of needs, hypertension and diabetes, those types of medications are usually continued within a jail. But for some reason, we tend to mess with people's psychotropic medications. And so how many folks do you have under psychotropic medications? Can you, looking at the types of psychotropic medications that are actually being delivered, are we making sure that we're continuing that? Again, if you have somebody come in, but you haven't verified the medications and they're not getting a fuller assessment for several days or weeks, that we're often then taking them off of those psychotropic medications. So how often are they discontinued or changed? And then tracking the data of all kinds of standard operating procedures for that kind of initial psychiatric evaluation. And again, are we really doing all that we can to make sure people are staying on? There's that continuation, that consistency of medications that they were on in the community, because that's likely what they're going to go back to again, instead of putting them onto a different kind of medication. And then looking at same types of stuff around medication-assisted treatment within the facility, and those MAT protocols. And then the average length of stay, so kind of pulling back out again to a bigger set of data. So when you're thinking about persons with specific needs who are in your facility, mental health, substance use needs, what's the average length of stay that's taking place? Is that longer than the general population? Oftentimes, and when I did this kind of work in Denver, we knew that they were staying for an average of 32 days longer than other populations over time, and that there was an average cost of $9 per day that they were costing more within the facility. So understanding some of that information. And then also looking at the same type of data for substance use disorders. And then again, do you have specific designated housing units within your system? Some jails are starting to move towards jail-based competence restoration. And is that taking place within your facility? Go to the next slide. The last couple of things here go back kind of full circle to where Ashley was talking about and looking at BIPOC versus non-BIPOC individuals within the facility. So what is the breakdown again? So looking at those kind of specialties, but are we also tracking all that different kind of data by BIPOC types of categories? And then I would always encourage you to not just look at race and ethnicity, but also gender and age across those different categories. And then we're looking at how ethnicity is defined within your facility. So some folks are still categorizing, say, Hispanic with white. And so you're not getting a clear picture of that particular population. Or we're not really looking at tribal affiliation would be another good example to be considering. And then looking, of course, at those populations by mental health, substance use disorders, and the type and level of mental illness and substance use, and then gender orientation in there. Looking again at the average length of stay, as Ashley was talking about earlier, that we know that there's a tendency for persons who are BIPOC identified staying longer within a facility. And also then the number of folks who are returning back to the facility because of revocations, so technical violations in particular. And specifically, we often see that around substance use or mental health concerns. So looking at the type of reasons why people are coming back into facility because of those technical violations. Go to the next one. Also want to pay attention, of course, to treatment courts. Sometimes we end up actually incarcerating persons more for longer lengths of stay because of technical violations who are actually part of a treatment court. So wanting to pay attention to that particular data. And then specifically looking at, and again, this will tie in more with some of the stuff that Sam's going to talk about later on, of those persons with that frequent jail contact, those familiar faces, and looking again specifically for them around BIPOC, race, ethnicity, gender, and again, mental health and substance use disorders. So I'm going to end there and turn it back over to Ashley to introduce our next speakers. But again, areas that we want you to just really kind of think about: are you tracking any of the information? How are you tracking it? Who's tracking it? How are you using the information? Thank you.
Thanks, Reggie. We knew that was a fire hose of information, but you'll get these slides. And we're also planning on releasing a resource that will be kind of a user-friendly guide to all of those specific questions. And I imagine as you're working through those, some of you thought, oh, we're doing that, or that's a good idea, or maybe we missed something. So if there are specific questions around this data collection at the jail level, please let us know if you think we missed a question that should go into that resource. And so we wanted to get your feedback as well. But thanks for that, Reggie. So now we're going to hear a bit from our sites, two of our Impact Network sites in Sarpy and Douglas County, Nebraska. And we have Joe Martin and Vicki Mecca representing both of those sites. So you should see your slides, and let me give you ability to advance. You should see that now, or I'm happy to. And I think you're muted, but otherwise should be all set, Joe.
Okay, can you hear us okay?
Perfect.
Sorry, we had some technical difficulties, but I think we've jumped in here. I was just trying to see.
I think there should be a little left and right advance, maybe on the slide itself towards the bottom, but if you don't see it, I'm happy to advance them.
Hang on for 1 second. There
you go.
Okay, yes. Well, I will start off with some introductions. My name is Joe Martin, and I am the Deputy Director from Sarpy County Jail in Sarpy County, Nebraska, and we're right in the middle of the country. I've been with the Stepping Up since we began in 2017, and we've completed 2 SIMs during that time and collected a lot of really good data. I'll let Vicki introduce herself.
Good afternoon. I'm Vicki Mecca, and I work for Region 6 Behavioral Health Care. We are the Regional Behavioral Health Authority in a 5-county area. 2 of the counties in that area are Douglas and Sarpy County. And Justine Wall would have been here today had she not been vacationing. So I am actually filling in for Justine Wall from the Douglas County Jail. But my role with Region 6, I'm the Director of Criminal Justice and Behavioral Health Initiatives, and I lead the Stepping Up initiative in this 5-county area.
So a little bit about Nebraska. We're right, like I said before, directly in the middle of the country. Most of the population is on this eastern half, which also borders Iowa. So we're part of the Omaha metro area. I think it's about 1/3 of the population is on this side of the state. So Douglas County is the largest county, and Sarpy County is just south of Douglas County, and we are the 3rd largest county. Lancaster, which is in a different region, is the 2nd largest. So a little bit about our state. We're known for the College World Series, Husker football. Everybody's very proud, especially back in the 90s when we had 3 back-to-back championships. Our Creighton Blue Jays, the Zoo, Berkshire Hathaway, and of course, Union Pacific. So to get into our Stepping Up, or both innovator counties, and kind of, do you want to say it?
Yeah, so both counties, Douglas and Sarpy, really formally started their work with Stepping Up in the fall of 2017. They had their county boards had passed proclamations prior to that, but they really got busy in the fall of 2017 when they each formed a Stepping Up team and really started to have those conversations about the 4 key measures, right? How do we define a serious mental illness? How do we define average length of stay? How do we define a connection to care? How do we define recidivism? Both became innovator counties in May of 2019. So it did take really a couple years to have all of those conversations, to get everyone on the same page, and then to figure out how are we going to collect the data. And I will just say this, with regards to data, that the Douglas County Jail is, as you can see, is a much bigger jail. Their capacity is, 1,400 versus the jail that Joe is responsible for, much smaller. Their new jail will have 362 beds for capacity and will be opening in late summer. And we are in it now. It's a beautiful, beautiful building. But one of the things that I have learned about data and extracting data from the jails is being bigger doesn't always mean better, and it doesn't mean easier. In fact, our experience is that being bigger has meant being more challenging to get the data, to really get the type of data reports you want real efficiently, because they're using a vendor versus Sarpy County, who is a smaller jail, but much more flexible and nimble. And Joe uses, and I don't want to speak for you, but she is able to put things in an Excel spreadsheet. And so any type of really data report that we need, she's able to get that very, very quickly for us. So
that's kind of made it easier to dial in on that special need, the high utilizer population. And kind of as time has evolved, now we are starting to focus on those, really dialing in on exactly the demographics, on who exactly this population is and what is going on with them.
So how we define serious mental illness, both stepping up teams, and there is, this was not by accident, but both stepping up teams use the same definition for serious mental illness. So they've identified schizophrenia, schizoaffective disorder, bipolar affective disorder, OCD, and major depression. It certainly works to the region's benefit to have both counties use the same definition, so that when we're looking at data, we're really looking at apples to apples. So it makes it a lot easier when they're using the same definition.
And also keep in mind, Sarpy County and Douglas County have, since Douglas County is so much larger, I mean, they're 10 times, we have currently 150 inmates. So their jail is about 10 times the size of our current jail. So their demographics and their population based that is being held in the facilities is a lot different than what we have in Sarpy County. So that affects just the pure volume of individuals that we are focusing on.
So then how are we identifying these individuals? So because of, I think it was both the SIM and wanting to use as much evidence-based or evidence-informed practices as possible, both teams have decided to use the brief jail mental health screen. That was one of the very first things we did in our stepping up work. So the brief jail mental health screen is administered during booking for everyone that's booked into jail. That's in both jails. A positive screen then will trigger mental health involvement. And I do want to just say this, I have found this, not having a criminal justice background, but having a behavioral health background, I just thought it was very, very interesting to see how just implementing the brief jail mental health screen, some of the pushback from the jail initially was, we don't have time for this.
And when we started this, our medical vendor is WellPath, and they used to screen with the brief jail mental health screen. So we transitioned that to our corrections staff during intake, that's part of the screening tool that they utilize. So that has enabled us to share with connecting individuals that bond out really fast to maybe like wellness court or wellness pretrial release or wellness diversion or mental health diversion. I think that we share that among all those departments, and we've seen a great improvement on connecting individuals, diverting them out, quicker than having them go through the whole process and screen individuals. So our nurse practitioner, our first, if they screen positive, our
Advanced practice registered nurse.
yes, our mental health counselor meets with them, and then if they are appropriate for needing medications, she refers them on to our APRN. We also have that do the self-reports, and also we have had we send our daily ends report out to other providers and community providers, so they can see if somebody that they're treating is now in custody, they can call up to the jail and maybe have that continuation of services easier. And I do want to add that all of our data that you will be seeing for our SMI population is confirmed diagnosis from our jail provider, that we're not using it from the brief jail mental health screen.
So Douglas County, as part of our stepping up work, we look at a whole lot of data, not we have the 4 key measures, of course, but then we also look at a lot of sub measures within each of those 4 key measures. So the first key measure with stepping up is to look at those individuals who are booked into jail with a serious mental illness. And you can see over time that this has been fairly consistent with about 20%. And again, we're using the definition of SMI with those 5 diagnoses that you saw earlier. We also know that about 40% of the population have a mental health disorder, but not a serious mental health disorder. And again, that number has been pretty consistent.
And that in Sarpy County as well. Ours fluctuates a little, and I do want to note on the last March of 2023, 27.5%, that little increase that we've had. We did adjust how we are reporting some of our numbers. So individuals that have been booked into the jail, but previously were here and did receive an SMI diagnosis, in our system. So we started including those in our reporting numbers. So I think that was the increase of those numbers within the last month, but we fluctuated from a low of 14% within the last 12 months to about 20, and it's pretty consistent.
The next slide is one that Douglas County is not able to report on this, but Sarpy County has been. We have been very curious about the number of individuals who are incarcerated that have a serious mental illness, but are charged with a misdemeanor. And through our conversations with Stepping Up, we really want to focus on those low-level misdemeanor crimes. And you'll see in the next slide. So we wanted to know by charges, which law enforcement agency is bringing these folks to jail with the misdemeanor offenses.
So within Sarpy County, we have the sheriff's office and then 3 other municipal police agencies. And as you can see, March was reported, but the number was 0. And over time, we have ended with some changes in our bond schedule, where they're just not bringing people to jail. I think all of our law enforcement agencies, we've done a great job at identifying these individuals on these misdemeanors and not keeping them in jail unnecessarily. And the law enforcement agencies have done a great job with diverting them and not even bringing them to the jail, because our numbers are so low for misdemeanor offenses.
I also think, and maybe this is a fantasy, but I also think that For the first several years of stepping up, we had the sheriff's office represented, but we didn't have the other law enforcement agencies. The sheriff was communicating information to them, and just this spring, we invited them to come to the table. And what do you know? In March, we have 0 people being brought to jail charged with a misdemeanor offense who have a serious mental illness. And
I think those conversations of just bringing the law enforcement to see, you know, what we have been doing and
what our goal is.
Yeah, and what our goal is and where we're trying to, you know, move this iceberg, that it is helping to get their buy-in. We've also implemented a mental health worksheet for law enforcement agencies. So they are, and they have also on the road have a mental health unit that is going out to follow up with these individuals.
So the average length of stay in Douglas County, the light gray bar is representing individuals that do not have a serious mental illness, and the dark green bar is representing people that do have a serious mental illness. So you can see that in Douglas County, folks who have a mental illness, a serious mental illness, are staying in jail significantly longer than those who do not.
And in Sarpy County, there's a large, you know, it's a pretty big disparity between the two. The gray, which is you can barely see it, which is averaging about 14 to 16 days. And then somebody that has a diagnosis of an SMI is a lot larger, to 119 days. So there is, you know, that they are staying in jail longer. And
some of that we know is tied with competency and competency being questioned, and the time it takes for someone to get evaluated. And then if they are found incompetent, there's quite a bit of time that they wait in jail, unfortunately, until they can get to our state psychiatric hospital for their competency restoration. So that impacts the length of stay.
But we've had great conversations and brought them to the table, our regional or state hospital, and we now meet with them weekly and have the outpatient treatment provider comes into the jail to meet with people on the waiting list in efforts to try to
engage them.
And we've had, you know, several, quite a few since we've started that were restored before they even needed to go to the hospital. So I think we're seeing improvements. We do not have jail-based restoration as of yet. I think this is kind of happening organically in our state, but we're improving the conversations and we're having better outcomes with shorter wait times.
And engaging people with medication, taking their medication compliance. So Justine wanted to be sure that that we had slide number 12 in here. They're very, very proud, as they should be, with some of the work that they're doing in reentry. They are using the GAINS short screener, the Ohio State TBI identification, the abbreviated post-traumatic checklist, the civilian version, and the TCU drug screen. And I would say these are all relatively new within the last couple of years. And then for recidivism in Douglas County, we track this as well. And the bottom line, the light green line, represents individuals without an SMI. And so in March, you can see that their recidivism rate was 34.6%. And that's for a total of 389 people. And individuals with an SMI for that same month, 60.3% for a total of 191. That's a lot of people coming back to jail who have a serious mental illness. So one of the next questions that, you know, is always there is, well, who are these people? How do we know what intervention to develop or what evidence-based practice to implement if we don't really know who they are, right? So because of the great work that Joe is doing in Sarpy County, you're going to speak to this, but we're going to get down to business in Sarpy County and really understanding who these people are.
And that's where, so our recidivism, we were at for a SMI about 42%, which represents 47 people out of 112. And then for the non-SMI population, it's about 15%. But now that we've had several years and, we really want to make move the needle on these things. So we're starting just with this next quarter is diving into the gender, the race, the zip code, and just get that client level data to focus in on to make these lines go down.
So it's one of the challenges with facilitating this stepping up is keeping people engaged, right? And when your data looks nearly the same month after month and quarter after quarter, it's not very interesting, right? It gets a little stale. Thank goodness people have stayed engaged. And I think now really the hard work is really going to just be beginning, because once Joe starts to send the region this client level data, we will really, these folks will become our friends. We are going to know a whole lot about them. We're going to be able to do some geo mapping and to know where are they living, what law enforcement jurisdiction is responding to their needs. Is our mobile crisis response touching these folks before jail like we want them to? Is our mental health unit and co-responder touching these folks? Possibly not, because they're back in jail. So where are the disconnects? We want to know ages. We want to know gender. We want to know race. We want to know as much as we can about who these people are so that we can develop the absolute best intervention to try and divert them from jail, right? And Joe is going to start with that, with sending us that data next month. So we're very excited. Now we want to talk to you a little bit about the Familiar Faces project, both in Douglas and Sarpy County. And I know that the term familiar faces, I guess depending who you are or where you are, may or may not be seen in a positive light. Douglas County, we are happy to change that when we can figure out a better term for the project, but we have not been able to do that yet. So we heard familiar faces from another county. We stole it, and that's what we're using now. But we have been utilizing this project or implemented this project about 3 years ago. When COVID hit, we really went on pause because the jail had other priorities. So, but we are back on track now. It's a collaborative project with the Douglas County Department of Corrections, the Douglas County Community Mental Health Center, the Omaha Police Department, and Region 6 Behavioral Health Care. The target population that we're looking to serve is people with 4 or more custodial arrests over the last 12 months. They have the documented presence of an SMI. They're willing to participate, will sign a release, and they intend to live in the Douglas County area once they're released from jail. And while our pilot project here is very small, we've only had maybe a dozen to 15 people. There are right now 125 people in the jail that would be eligible based on this criteria. So it's even hard to say that because, and the project is very small because of the case management availability. We're kind of borrowing staff from the Community Mental Health Center at this time, while we're trying to identify funds to fund a full-time case manager. The other reason is that it's so small is that these folks are getting case management. It starts while they're in the jail, but it can continue and has for some of these folks for 2 years. So it's a long walk with these folks. And we have identified that as being very, very important, that this is not a one and done. This isn't a 30-day and then we part ways. These folks really need that long-term case management. So, anyway, the region funds part of this service. It's called Emergency Community Support. And we fund the first 90 days, but then the county funds the remainder of the time with them. And that connection does start before the inmate is released. The There's a team that comes together. We meet every 2 weeks face to face, and we get an update from the case manager. We've also Zoomed family members to be a part of the meeting as well. But honestly, these are very, very complex. These are people with very complex needs. They often have SUD along with their SMI. They are often homeless. They have been served by multiple providers. They're not real interested in taking their medication. They don't keep appointments real well.
And do we, does Douglas County, do they pair them? Because it's all through Douglas County's Community Mental Health Center. So they asked, it was a familiar faces with an assisted outpatient treatment program.
Yes, not in the way that they're probably thinking about AOT.
Okay.
No.
And they also, Douglas County uses the same definition for recidivism as Sarpy County. So we had many meetings on recidivism, but we came to the conclusion that it is a 12-month prior admission, not like new charges, but it's just prior admissions into the jail. So, what they could be coming back in jail, or maybe they violated their pretrial release, or maybe they're serving a probation sanction, but we do how many admissions over the prior 12 months.
And in Douglas County, with the first cohort of 8 people, the data is very, very clear that we have reduced the number of jail days for this population. We have increased the amount of time in between incarcerations. But the data is all very, very positive but it's just such a small number of folks at this time. But we are really hopeful that within the next probably 90 days, we will have a full-time case manager just devoted to the Familiar Faces Project in Douglas County. And then the Sarpy project is called something different. And I'll let you talk about that, Joe.
Okay. So we did change the name from Familiar Faces and came up with the Specialized Transition Planning, STP. Most of our resources that we utilize are located in Douglas County. So we do utilize our partners, I guess, are listed: the Sarpy County Department of Corrections, pretrial mental health case management, the Sheriff's Office Mental Health Unit, public defenders, county attorney, Salvation Army for case management, and also we've just added, which has been tremendous, the Douglas County Community Mental Health Center for case management, Santa Francis House, and Region 6. And we debrief. They start at the jail level. They do have a diagnosis of an SMI, and they come in, do the in-reach in the jail. So they have that soft warm handoff when they go out to the community. And the criteria is a little bit different because we had to kind of tailor it to what met the needs of our population. And it is the documented, like I said, for the SMI. And then they're identified by our reentry staff and our public defender as high needs. And also they're willing to participate, and they intend to live in Sarpy County upon discharge.
And that was really your next slide. So,
Was that?
Yep.
Oh, okay.
So then just one last thing we wanted to share with you. I think just about at every one of the Stepping Up meetings, whether it's in Douglas or Sarpy County, folks bring up the challenges with information sharing. We had John Petrella here in December of 2019, and he did an all-day presentation. He's a wonderful attorney who specializes in HIPAA, right? He came, Region 6 brought in mental health and criminal justice stakeholders. And at the end of the day, he basically said, folks, HIPAA is not your problem. Your problem is you have a state law that prevents your licensed mental health practitioners from sharing with other mental health practitioners protected health information without a consent. That's your problem. So we got busy. We formed a work group. This was right after John left. to look at that state law and what could we do about it. I am so excited
I know.
because just 3 hours ago, this is the last day of our legislative session, and the bill, our bill was LB 37. It was amended into another bill and it passed today. It passed. So our state law now will be reconciled with, and will look just very much like HIPAA. That threshold of sharing information is now going to be reconciled. So it's really, really exciting. We have a lot of training to do, a lot of educating with mental health practitioners. And I am a mental health practitioner. And so I feel comfortable saying this, but they'll still say, well, HIPAA doesn't allow me to do that. Well, actually it isn't HIPAA, it's the state law. So you're wrong. But now we'll be able to say, no, even the state law, you can. But it's going to take training. It'll be a culture shift and it'll probably take us a good couple of years, but at least we're in the right direction and folks will no longer, and this is kind of mean, but be able to hide behind the HIPAA thing or the state law. Those days have to be over. This population of individuals, they're being assessed and reassessed and starting over with medication that we knew 2 years ago wasn't working for them. It's not going to work for them today, but because we're not talking, we don't know that. And so it should be of no surprise that our recidivism is what it is.
And I think one of the things that is so interesting, we're all in this, we all want the same end goal with this high needs population, but we are so siloed with our information and just communicating amongst departments, even in the same county, let alone like with another, the adjoining counties. So we have a large work group and we are collaborating and developing software to share all this information. So so we're going to start kind of small and share it between police, the jails, and want to, eventually add in practitioners and just, so you can have, does this person have a contact person that, or a RAP plan? And, can we connect them before they even have to come in contact with the criminal justice system?
So our behavioral health criminal justice information sharing strategy was twofold. It was that state law, and then it was to look at purchasing some software or having a vendor develop software that would connect our disparate data systems now, because they don't talk to each other. Like Joe said, even within county government, they don't talk. So Region 6 has taken the lead. The partners are Omaha Police Department, the Sheriff's Office in Douglas County, Sarpy County Jail, Sarpy County Sheriff, and the Douglas County Jail in Region 6. And Region 6 is taking the lead with writing an RFP that we're releasing the end of July, and that will all share the financial cost of whatever that is. And like Joe said, we're going to start small and kind of build our way down the road, but we're really, really excited to be able to start sharing information with each other.
And I think the leaders of both counties, they're at the table and really have committed and are on board with this information sharing. And it's really exciting. And thank you. We're super excited that it just happened.
We haven't even gotten to celebrate yet.
No, we've been trying to hook us up to this new system. But
So, and the last slide is just our contact information. If you have questions or want to reach out, our Stepping Up packets are all online at region6.com. If you look at go to the criminal justice icon, every packet of data that we have from the very beginning is there if you're interested. And how do you ensue a warm handoff? One of the challenges we face is not knowing the time when someone is released. Yeah, so do we. So we identify people that when we know they have a release date. So they're within 30 days of leaving. We usually target the sentence population first, and then folks that we know or are likely to be leaving in 30 days or so. Other caveat with that is because Region 6 is paying for the first 90 days, we only allow the provider to spend 30 days in the county jail. We won't pay for them to be we won't pay for that month if they're there longer. So they're very careful about who it is that they're completing an intake with.
And our community partners will come up. They've, upon release, to meet with them to make sure they're not, just being set up to fail and just be released to the community, never to be seen. So they are really proactive at contacting, meeting them up at the jail or getting out to their house, within that 24-hour period when they're, the most vulnerable, entering back into the community.
One of the other things in Douglas County that we have learned, and this is not anything like just super amazing, but it's the simple things, right? Is that we need to do a better job of identifying family. Because often providers will say, well, no, they burned those bridges. Well, they had burned those bridges, but it's family members take a very different look at these folks when they know they have a team of people behind them. It's not just you, mom, and your son or your brother or your husband. It's a team of people that have got him now. So will you come and meet us part way and start to reconnect with this person? And we have seen some really amazing things happen. We've brought in grandparents and we've brought in aunts and uncles, and it has made a significant difference. But initially, in the jail staff, they'll say the same, well, no, he doesn't have any family. Well, everybody's got family. I was in child welfare for 25 years. Everybody has a family member. It just takes time to identify them, right? And re-engage them. So,
and also get the buy-in from jail staff and, what are the leaders of the jail and their views, on the programming that does come into the jail, and just really having the staff support the programming and the reentry staff. It makes a huge difference.
and I would say that in Sarpy County, Joe is my go-to person in Sarpy. She's my partner. And in Douglas County, it's Justine, who's over all the mental health and the rehab services. So I think those partnerships, she knows criminal justice and I know mental health. So it's a really nice fit.
And we also, when did we start that? Last fall? We have a meeting between Justine and just trying to focus on some of those shared goals.
Yeah.
So we can really make that needle move.
Ashley, we're probably at our time.
Yeah, sorry.
I'm gonna jump in here, and Joe and Vicky, great job, great just demonstration of, again, partnerships, just what you guys were just talking about the use of data and understand who your populations are, kind of that population health approach, and the partnerships, right? That this is, jails are not an island. They are a hub in the process, and we have to create those spokes to connect them to services, and that we can't create cliffs in that kind of process. And you guys are just doing all kinds of great stuff with that. And then using, high five, using information, right, to be able to push policy. So it's not just looking at the practices, but you're looking at policy at every level, from, looking at how you're identifying folks, how you're using the data, using those definitions. I remember we had 7 jails that came together in Denver, around Denver. We call Denver the donut hole, right? And it took us 6 months with the psychiatrists and the jail providers to come up with the definitions of what serious mental illness was, because everybody was saying it differently. So appreciate, right? You think it's easy, it's not. But just really great example of all of that work. Before I go hand it back to Ashley and we bring in Sam, I want to just kind of pull back. First of all, you got a lot of high fives from the whole group about talking about natural supports, right? And how you're identifying those. But also in really thinking about how are you connecting people around transition. So Monica, I don't know, I know that I think it was Vicky was speaking at the time, was responding some of your question about those transitions, but I didn't know, Monica, if you had any follow-up to that or to the outpatient assisted treatment that you wanted to follow up on as a question.
Hi, Regina. Hi, everyone. They answer the questions we're just working on our reentry program and how to follow up. So I think this data is going to help us keep track of that. And we just need to find ways to ensure that warm handoff, because we know that once they leave, it's very hard to track some of the clients.
Yes.
So that's why my question on the warm handoff. And regarding the AOT, we do have an AOT program, and we're working on a familiar faces program. So we're going to pair all those elements together. But thank you for the great presentation.
Oh, thanks.
One other thing I would just add really quickly, when we first started the familiar faces, one of the things we did was I reached out to the pharmaceutical representatives who have samples of the long-acting injectables, right? And so we got to be friends with them, and they now, the prescribers in the jail are able now, when it's clinically appropriate, to prescribe an LAI and get that sample free. And then the community mental health center, once they're out, they're able to access free samples. If they're not on Medicaid or don't have another payer, they can use the free samples at that clinic. And that has been a game changer for the case manager with the familiar faces or STP to be on top of when is that next LAI due, and making sure that they have a ride and that they get to the clinic to get the injection. So that's been,
Just a game changer.
it is a game changer. It's a game changer for people. Yeah. So
I'm so glad you brought that up, Vicki. One of the, because pharmaceutical companies are always coming out with things, and a lot of times they offer some of those kinds of little new shiny toys to mental health centers, but most of them are willing to also work with jails, and you're really kind of creating that consistency and continuity through that. And for some of our folks, the long-acting injectables are really the best way to go. But for a lot of folks, they see them as being cost prohibitive, so that's great.
yeah.
I have a question for you, and if anyone else has a question, please let us know that by raising your hand. But are you using, you were talking about case management and some of those particular challenges. Are you using any of your block grant funds? So the state block grant funds can be used to provide services in a correctional setting. Are you guys using those at all?
Yes, so not in that way. Our state block grant funds come to the regional behavioral health authorities, the 6 regions across the state, and they're used, because those dollars are flexible, they're used in a variety of ways that our state general funds can't be used, but they are not used to fund anything in the jail now. Douglas County has a really nice SAMHSA grant where they're delivering intensive outpatient substance abuse therapy in the jail, but those are SAMHSA dollars that don't funnel through the state. But no, none of our block grant, but you're making me think about a couple things. So thank you for that question.
Always looking for money, right? And the
Yeah.
part of that is, do you have specific data that you're going to be collecting around that difference that makes to have those supportive kind of case management services?
Yes. So I think that's an area where the partnership is really important, because the jail, does not have a data analyst. Joe collects data and she pulls data together in reports, but we have a team of people who do data analyst work. And so they're able to break things down, to look at cost, to look at all kinds of things that Joe and I aren't able to do. So I also think once we get that client level data, we're going to really be able
I think
to,
that is going to
that'll be our
really
game
dive
changer.
in for us. So.
Yeah.
Part of that is having a standardized reentry checklist, right? So that you can aggregate that information through that. I'm not seeing any other questions. I do want to also just note, so kudos on the HIPAA and understanding it is the Portability Act, working with your state to be able to reduce, so that is aligned with HIPAA and isn't more restrictive. There are several other states that where it is more restrictive and it can be really problematic. And then also I'm wondering if in any of your work, if you're using like Power BI, which is free under Microsoft 365, that can pull in all your Excel tables and create beautiful dashboards.
So we use Tableau.
Okay, that was another great.
And that's about all I can say.
Yeah.
That's what we use.
Okay, great. Yeah, great tools. So
Okay.
any other questions from anybody? I don't see any hands raised. Actually, am I missing anything, or does anybody want to just jump in if you've got a question?
I don't see anything else. We'll have a little bit of time at the end of Sam's presentation too. So I'll echo Reggie's thanks, Joe and Vicky, that I think that presentation was perfect. And you don't know this, but it leads beautifully into the next presentation. So you had so many call outs that I thought were worth reiterating. I appreciate that. As I turn it over to Dr. Zatola for the next piece, I want to speak to the term in particular that we're using, frequent jail contact. So as you are in Sarpy and Douglas County, we have been using familiar faces for quite a while, or most visible persons, MVP, and still use that a little bit, honestly, although our research area was the first to introduce us to this people with frequent contact or frequent jail contact. So it's maybe a little bit more clunky, but even more person first. So you'll hear maybe even those terms used interchangeably, but that's the group that Sam will be talking about in just a minute. So happy to hear this discussion of stigma and terminology, as well as how we're doing this work. So I'll turn it over now to Dr. Zatola, and she is a colleague of Reggie and myself in our research area at PRA, and we'll talk about some collaboration across our areas and the work that she's been doing. And she'll be a familiar face to those of you who are in St. Louis. Sam?
Yeah, thank you so much. I'm so excited to be here. Like Ashley said, I am fresh off of a project that was funded by MacArthur. I was partnered with some of the SJC sites to kind of look at this population of people with frequent jail contact. We actually had our wrap-up meeting right before this call. So like I said, really fresh off this work. I'm excited to kind of talk about it a little bit with you all. I'll go through my slides, I think, kind of quickly, but definitely happy to answer questions. I don't know, Ashley, if I actually am able to advance. Can you just go to the next one? Oops. Sorry, I'm going to stop trying to click buttons.
That's okay, I can do it.
Okay, thank you. You can go to the next one. Thank you. So I'm going to just really briefly kind of talk about some of the prior research on people with frequent jail contact and kind of what this population looks like based in some of the reports and papers that are out there on this group. And then I'll talk really quickly about some criteria that can be used to define frequent contact and to really establish kind of who this population is. And then make just a couple of points about why defining frequent contact matters. Although, like Ashley said, the presentation right before me really, I think, was like a brilliant example of why definitions matter and what you can do when you have a definition. So I'll really just kind of be reiterating some of what they said. So to kind of just go really briefly into some of the research on this population, at the start of the project that I just wrapped up, we spent a little bit of time just kind of scanning the papers and reports that were out there on this group to kind of see what the sort of big picture of people with frequent jail contact, what they look like across the country. And this is a population that is, I think in practice, folks have known about this population for a long time, but it's kind of new for the research world to start looking at this group. So there's not a lot out there. We only found about 12 to 15 papers or reports, and they were all kind of recent. They were all just from within the last couple of decades, but pretty consistently across the research, kind of again and again, what we see is that this is a small population that has large representation in the systems. So I have a couple examples here on this slide, but I'll just call out this Miami-Dade example. This paper found that 5% of people who were involved in a jail diversion program made up 25% of the referrals. And just to kind of put that even more concretely, that was 97 people who accounted for nearly 2,200 arrests, 27,000 days in jail, and 13,000 days in crisis units, state hospitals, and emergency rooms over a 5-year period. So this is typically a very small group of people who are having a huge impact on systems and services, and that's really consistent across studies. Go to the next slide. In terms of the demographic characteristics of this group, they are predominantly people of color. That's coming up kind of again and again in studies. Across the studies that we looked at, about 30 to 95% of the population was Black, 15 to 55% Hispanic, 14 to 66% were white, And then about 1% Asian, 2% Native American. But I do want to say that I think the low rates, particularly of Native Americans, might actually more reflect where these studies have been done. Most of them have not been done in areas that have high Native American populations. So in the project that I just wrapped up, one of the counties that we worked with had a pretty high population just in general of Native Americans in that county. And we found that in that county, 65% of people with frequent jail contact were Native American. So I think that that percentage, that low percentage that's kind of showing up nationally in studies might be that studies just typically haven't been done in areas with large Native American populations. This population is primarily men, and the findings on their age are kind of mixed. So some studies find that they're younger than the kind of broader population of people who are having jail contact. Some studies find that they're a little bit older. In general, the age range is about 35 to 50 for these folks who are cycling through the jails. Next slide. Consistently across studies, people with frequent jail contact are found to have very high rates of homelessness, very high rates of mental health concerns and substance use. And it's very common for mental health and substance use to be co-occurring in this population. And there's a lot of discussion about from folks who work in the field and from the people who are experiencing the cycling themselves, that these unmet needs are what really contribute to cycling. So that experiences of homelessness, experiences of substance use that's not being addressed, that is not being, the resources are not available. These are the things that contribute to why people cycle through the jails. So how can you develop a picture of the size of this population, the demographic characteristics, and the needs of this population, if that is something that you haven't already done in your county? The way that you can do that is by creating a definition so that you know who you're looking at when you want to kind of dig in on who this group is, what they look like, what their needs are. So I have 4 criteria to kind of offer. So the 12 to 15 papers or so that we found in the literature that have kind of studied this population and focused on this population, we looked at the way that this group was defined across each of those studies and kind of distilled all of those different definitions down into these 4 criteria that can be helpful in kind of setting the boundaries around who are people with frequent jail contact in your jurisdiction. And I'll just kind of go through the criteria quickly because they're pretty, I think, straightforward. The first criteria is the type of contact that you're looking at. And this is just the type of contact that you want to be counting, whether it's number of arrests, number of bookings into jail, number of convictions, maybe number of 911 calls. Rather than counting the discrete number of contacts, you might also count kind of a time span. So it might be days in jail or days on supervision. But this is just the type of contact that you're focusing on. And this is really kind of the root criteria. Everything else builds off of this one. So the next thing is the number of contacts. And this is just kind of the boundary that you set. Anyone below the number does not meet the criteria for frequent contact. Anyone above the number does meet the criteria. And there are kind of 2 ways you can set the number. You can just set a threshold, like 3 or more bookings. And I know that's the threshold that the MacArthur Foundation, I think, is using in a lot of their work, 3 or more jail bookings. You can also look at the total number of people who've been booked into a jail, or if you're a service provider, the total number of people who have access to your services, and look at the top people who are most frequently being booked or most frequently accessing services. So that might be, the top 800 people. It might be much smaller. It might be the top 60 people, the top 10 people, whatever group, whatever size group you have the resources and the kind of person power to focus on. The next criteria is the time period. So this is the period of time over which you're counting contacts. And this might be, 1 year, 3 years, 5 years. It could be shorter. It could be 6 months. This will kind of depend on the type of contact that you're measuring and really whatever time period is meaningful for that type of contact. Some types of contact, it may make sense to measure them over a longer period of time. Others, like ER visits maybe, or 911 calls, those may make sense to be measured over a shorter period of time. And then the last criteria is additional systems. So this is the inclusion of contact across multiple systems. So if you're trying to develop a definition just within one system or one agency, you might just focus kind of on the first 3 criteria. But if you want to develop a definition that kind of goes across the city, across the jurisdiction that everyone is using, then you can kind of use the first 3 criteria to set definitions within each system or agency or service, and then bring them all together to create kind of one overarching definition. So an example at kind of a city or county level might be a person is designated as someone with frequent contact if they have 3 or more bookings, 4 or more ER visits, and have spent 6 or more weeks in a homeless shelter over a 2-year period. So that would be kind of an overarching definition that includes multiple systems. Thank you. Setting a definition is completely a local decision. There are really no national standards or guidelines out there about how to set a definition for frequent contact. So this is really up to you all. It's whatever you have the data for, whatever you have the resources for, and what makes sense for your goals in working with this population. Like I said, you can kind of go 2 ways. You can set individual agency or system definitions that you then use to collaborate across systems and agencies, or you might set one kind of city or jurisdiction-wide definition that everyone's using. It's really important to consult and collaborate with multiple partners when you're deciding on this definition and making sure that kind of all voices are at the table, so that everyone buys in on this definition and so that the group of people that you end up identifying will be relevant for everyone. Another thing is just to consider the label. And I definitely don't raise this point to put anyone on blast. I know frequent or familiar faces, I know that's a really common label that's being used. I just raised this point kind of as something to think about, particularly in counties that maybe haven't already started to put programs or projects together to really look at this population. Just think about the label as you're starting off. And then the last recommendation is to document your definition. So like I said, there are no standards. You can really do whatever works for you. The most important thing is just that the definition is clear, that it's applied consistently, that it's documented, so that everyone is on the same page about how this group is being defined. And then the last thing to talk about is why the definition matters. So like I said, I think here I'll really probably reiterate a lot of the great points that have already been made. Next slide. But the first reason that having a definition really matters is because you can't look at this population if you don't know who they are. So in those first slides, when I talked about the size or the demographics or the needs, that information could be produced because each study and report had developed a specific definition of frequent contact. So then the researchers or the folks who are working with data can go into the jail data and the court data or the service data, and they can pull the sample of people who meet that definition and then really dig in on what's the size of that sample, what do they look like, what are their needs. If you don't have a definition, you don't know what you're looking for when you go into the data. And if you're not looking at the data, sometimes you're kind of just guessing at who this population is or what they need. And that kind of brings me to the second point, that experiences or expectations about who this population is don't always match with data. So you might feel like you really know this population because you recognize them, you see them, they're familiar to you. But what we see sometimes in the research is that the kind of conventional understandings of who this population is don't always match what we see in the data. And this can mean 2 things. It can mean that the conventional understanding is maybe a little bit skewed, which sometimes happens when you're working on the ground, person to person. You don't always have the big picture view of everyone that's included in this population, and that's fine. As one example of this, in our study, one of the counties that we were working with, practitioners said that people with frequent contact were cycling on low-level offenses. And this has been found to be true in other studies, but in that particular county, when we looked at the data, what we saw was that people were actually cycling on felony offenses, which was very unexpected to us and to folks in the county. And that's not what people thought was happening, but people were actually cycling more on felony offenses. Another example is, I was just listening to a talk, someone in Johnson County was presenting on some of the work that they're doing around folks with frequent jail contact. And this person shared that when the county first started the work, they expected that the peak time that people who were cycling would be coming into the jail was like Friday, Saturday nights. But when they actually started looking at the data, what they saw is that the peak time was like in the middle of the week in the afternoon, which was really not what they expected until they went to the data to kind of see when folks were actually coming in. Another thing that can be happening when data and expectations don't line up is that sometimes something is not accurately being captured in the data. And this happens for various reasons, but is a really helpful thing to learn so that it can be corrected. And an example here is another one of the counties that we were working with. Everyone that we spoke to mentioned the really high rates of mental health needs among this population. And again, that's something that has been seen across counties. But when we looked at the data in this county, we looked at the mental health screen that they were using in the jail, And it was only something like 3 or 4% of people were being flagged positive by this mental health screen, which could not have been correct. The screen was clearly not picking up as many people as it should have been picking up. So this is something now that the county is working on, adjusting their mental health screen and kind of what that process looks like so that they can make sure they're catching all the folks that they need to with that screen. And then another reason the definition is really important is having a definition can help jurisdictions ensure that they're reaching the right people with the right services. So if you know what the population looks like and what their needs are, then you can really target them for services. And you can also figure out the best way to deliver services. So like that example from Johnson County, if they had wanted to put a program in place where someone was, in the jail to make contact with folks, and they had tried to put that person in place on a Friday night, they wouldn't have been catching people. It wasn't until they looked at the data and saw when folks were most often to be cycling that they realized they would have to put something in place, in the middle of the week in the afternoon. So looking at the data really helps you figure out kind of the best methods, not just the best services, but also the best methods for reaching people and the best methods for service delivery. And then finally, if you have a definition and you're tracking this group, you'll know if services are working because you'll know when you're not seeing them anymore, and you'll know why you're not seeing them anymore. And this can also be really important for evaluating whether services are working overall, and like Ashley kind of talked about, whether they're working equitably, making sure that services are reaching people equally across gender, across race, across class. Because when you put services and programs in place to reach people who are cycling, you work really hard to do that. You work very hard to put those programs in place. Those are big efforts. And so defining this population will maximize your ability to make sure that you're reaching folks, that you're reaching them, and that the services are working that you've put into place. I feel like that was very fast, but that was my talk.
Thanks so much, Sam. There is a question around for you, but also I think for folks from Nebraska, if they're still able to speak around, did your research look at any costs associated with this population?
My study did not look at any costs. We just didn't have access to any kind of cost data. Although I know I've heard Reggie talk about that before.
I was just going to say that it wasn't until we allocated costs, because we first started our familiar face work back in 2012. What I heard from folks is, Reggie, those are municipal warrants, or those are misdemeanors, and they really don't stay very long. And I'm like going, but they're there a lot. And they're costing the whole system because our attitude is they don't really matter. Nobody's paying attention to them. So when we did the cost analysis, we found that they were staying in jail for an average of 57 days. And the frequency, we costed out the cost to do bookings, to do a citation versus a custodial arrest, for that cost, for the booking cost, for the medical cost, all that kinds of stuff. So it became astronomical, really. People went, oh, shoot. They actually are costing us a lot of money. And in fact, $26,872 per person per year was the average cost of those persons. So cost really does add up. Vicki and Joe, are you guys looking at cost?
Yes, so in Douglas County, with that group of 8 individuals, that initial cohort, we did attach some costs. We really looked at, we used the daily bed rate that the jail had, and we looked at the number of jail days that jail day savings, right, or the jail days that didn't occur. And for those individuals over a period of a year, it was pushing right at $1 million. So it added up very, very quickly. And I don't remember if that included the psychotropic medication, but it wasn't much more than that. We would be very interested in looking at, the system-wide costs, of, with the courts and emergency. Emergency rooms. We aren't there yet, but we also have found that it really gets people's attention when you start talking about dollars, right? And costs and cost savings. So I think the sooner that we can get better at that, probably the better.
I really appreciate that response. And if I can just add to that, is that it's likely there is going to be a cost shift, and probably not a cost savings or avoidance, but really looking at, and so you have to have all your partners together to understand where should those costs be. Although when we matched it then with doing housing, we were able to see the cost reduction. So we were able then to really show the reduction in the cost. But if you don't do anything that really stabilizes the population with both treatment services, case management services, and housing, chances are it's going to be more of a cost kind of shift on any respect. So that becomes a really important part. The other part that I think that this cost conversation brings up again is really having the conversation with your state Medicaid, whether you're expansion or not, about who's actually being served right now. Because one of the things that we found is that people simply were not getting the services because they were so frequently coming through. And especially with that misdemeanor kind of municipal warrant population, they tend to go through so rapidly. So sometimes our systems have gotten so sophisticated that they're in and out before we can get our hands around them to be able to deliver services. So one of the other things to think about is how do you do that proactive work with, especially with your familiar faces. You kind of know who they are. You not just kind of, you do know who they are. You know largely what their needs are going to be. And so starting to do that kind of proactive work that's both community structured and also facility structured, so that when you've got somebody that you're doing that kind of next step of wrapping around them. Other questions that anybody might have for Sam, or other thoughts that this has spurred for folks in today's webinar, the meeting. Seeing none, I know that Ashley, you want to talk about another resource. And again, through the Impact Network, this is all about you guys learning from each other, and then also let us know as the PRI team about what kinds of things that you need. And we're happy to help you kind of think through different kinds of strategies. So Ashley.
Thanks, Reggie. Great segue. One thing we heard clearly is that there are no national standards around this group. So you all are creating those national standards. So please reach out to us if you want to have a one-on-one site call around these data issues. We're thrilled to do that. We do have this other resource. I know we're out of time, but we'll send this out to folks. It's a new infographic based on the research that Sam was talking about. And you're the first actually to get your eyes on it. Just finished this week. So we'll send it to you. It's specifically around that definition piece. So it talks about what to consider, what not to consider, different criteria as Sam broke them down to consider in creating your definition, some examples, and then where to start from a policy perspective. So kind of a quick, easy at a glance on defining this population in particular. But I will let you all go. A huge thank you again to all of our presenters and to all of you, and reach out with any questions. We'll send out their recording. Thanks, everyone. Take care.